So good afternoon, everybody. It's so nice to be joining you from the Department of Obstetrics and Gynecology. Dr. Albright and myself are just going to briefly introduce ourselves. We are both in the Division of Maternal-Fetal Medicine, which means we provide obstetrical care and high-risk obstetrical care to people with a variety of different pregnancy complications. We both have some kind of personal and professional interests in endurance training, and then like a lot of professional interest in training in pregnancy. So with that, I'll turn it over to Dr. Albright.
Great. Sorry, you had not allowed any guests to unmute themselves, and I was still
Sorry.
guest. So no, that's okay. Thanks, Alyssa. I'm Kat Albright, also in the Division of Maternal-Fetal Medicine. I've been in Washington for about 6 years, or I guess now 7 years. That seems crazy. As a member of the Department of MFM, and as she said, we were asked by our chair as a response to this talk, in part because I think we both actually just have a personal interest in the topic, not so much because we're physical, like occupational medicine or physical therapists or anything like that, just because we both find it interesting. All right.
Okay, so with that.
All right, so this is just my fun. So when I first got into this was during my medical school and residency training. I was in New York City in 2007, and Paula Radcliffe won the New York City Marathon in 2007, and she was 11 months postpartum, which no one really, I don't know that anyone really knows, but it's actually, I think, really impressive. She really never stopped training during her pregnancy or postpartum, and was running, an hour to an hour and a half every day during the entirety of her pregnancy. In the very end, apparently she cut back to an hour in the morning and then just riding her bike at night, which, big decision to cut back. Also in 2007, I also ran the New York City Marathon. That's me on the right-hand side. We had a friend on the Verrazano Bridge who was taking pictures. And so that's me and a friend. I was neither pregnant nor postpartum and was, an hour and a half behind her. So endurance training in pregnancy is possible, as you can see. But I'll move it back to Alyssa.
Okay, so here are our learning objectives that we're going to cover throughout the talk. And then I'll pass it back over to Kat.
All right. So we wanted to I wanted to start with just giving a little bit of background just about like physical activity in general, and then physical activity in pregnancy. So when the World Health Organization kind of looks at physical activity and physical inactivity, it's really been quoted that inactivity is the 4th leading risk factor for early mortality worldwide, which is really, I think, an impressive statistic. And the WHO and the American College of Sports Medicine, neither of which I am particularly involved with, have issued evidence-based recommendations indicating that the beneficial effects of exercise in most adults are really indisputable, and that the benefits really far outweigh the risks for the vast majority of people. When we think about pregnancy, which is where Alyssa and I mostly live, physical inactivity and excessive weight gain during pregnancy very clearly increase the risk of obesity, pregnancy-related complications, including, but not limited to, gestational diabetes.
Okay,
all right.
So I'm going to take it into the physiologic adaptations of pregnancy. And my only disclosure for this talk is that I have never run a marathon. I've run many half marathons, including one when I was about 7 weeks pregnant. And my mother was very concerned about that. I told her the pregnancy doesn't work like that. It's not like running is going to do anything bad. But it was like a few days before I felt really awful for like 3 months. So there are definitely significant adaptations that occur during pregnancy. They are idiosyncratic, so they don't happen and are experienced in the same way for every single person, but every organ system will undergo changes to accommodate the growing fetus and the placenta, and to really accommodate and help the fetus grow and develop into a full-term pregnancy. So that ranges everything from your cardiovascular system all the way down to your skin. Some of these changes are more profound than others, but every single one of them will undergo some changes. Some of them cause symptoms, and some of them don't. Some of them cause serious symptoms in some people and none for others. So we're going to just walk through a few of these physiologic adaptations to put some context about why people who are pregnant are a little bit different in terms of how their body functions. So first of all, and this is one of the most obvious things, is that the uterus grows substantially during the course of pregnancy. As you'll see here in the figure, we have an 8-week size uterus, which is kind of about the size of a pear or like one's fist. And then we have the 40-week size uterus that goes all the way up to the diaphragm. And I usually refer to it as about the size of a watermelon. It's highly variable in different people, but that's about the scope and size that we're thinking about. Along with this increase in uterine size, there is also compression of the internal organs that are near the uterus. So this seems very obvious, but the bladder is right in front of the uterus. The bowels are along the side of the uterus. Your kidneys and then the tubes that connect the kidneys to the bladder also get compressed. The diaphragm is up top, which kind of limits the ability to take full deep breaths. And then the pelvic floor is kind of the hammock-like support system inferiorly in the pelvis that kind of keeps all the pelvic organs and the uterus up. So uterine blood flow increases proportionally with the size of the uterus. And what's really important about this is that there is extra blood volume circulating around that we'll talk about, but a lot of that extra blood volume that's getting pumped by the heart with every single heartbeat and cardiac cycle is going to the uterus. So that goes from a very small amount, which is about 50 mLs per mil, to over 500 mLs per mil towards the end of pregnancy. So this is a gradual increase, but when people say they have things like pregnancy brain, I'm pretty sure what that means is that there's overall a lot of blood flow is being diverted. A lot of the cardiac output is being diverted to the placenta in the uterus and less so to people's brains. That's not really a thing, but people do uniformly discuss that there are different changes that they may experience based on this differential blood flow. In addition, there are many cardiovascular changes, and people experience these to different degrees, really based on their level of physical fitness and conditioning at the beginning. But there is a small increase in the heart rate, which kind of makes sense because the heart is working a little harder to pump all this extra volume around. There's a big increase in volume, and that's the stroke volume. That's like every cardiac cycle, the heart is squeezing more volume around to try to get to all the critical organs and the placenta and the uterus. In order to deal with this increase in volume and heart rate, there is a compensatory decrease in peripheral or systemic vascular resistance. So that is essentially blood pressure goes down, especially the blood vessels in lower extremities and other big blood vessels dilate. And so people will experience things like fainting or dizziness, we call that syncope in pregnancy, or other physical symptoms that have to do with that relatively lower blood pressure in pregnancy. As we mentioned earlier, the blood volume does increase substantially during pregnancy, and this is to help that heart that's working harder circulate extra blood volume around and to get all that extra blood to the placenta and the uterus. There is also an increase in one's red blood cell mass. So although there's more blood volume, that is relatively dilute compared to the amount of the red cells that increase. And that creates a physiologic anemia during pregnancy. Now, some people will experience this anemia and as kind of feeling tired or fatigued. Some people will have no symptoms at all because it is a very gradual process. 6 weeks postpartum, this returns to baseline after all of that extra blood volume has been diuresed and the system kind of resets back to normal. Now, there's also a number of pulmonary changes, and this is not surprising in any sense because as the gravid uterus extends up towards the diaphragm, there are limitations in terms of how deep a breath someone can take. So if the lungs cannot expand in this direction, actually they often expand in this direction, and there's like relative expansion of the chest wall. During pregnancy, there's an increase in many of the hormones. Many of them cause different side effects. But one of the ones that affects the respiratory system is that there's a lot of progesterone. Progesterone causes a relative sense of shortness of breath, or what we call dyspnea. It is probably because the progesterone is trying to get you to breathe off more carbon dioxide to aid in the kind of the way that carbon dioxide is processed through the fetal and the placental compartments. But in doing so, people feel short of breath. And they sometimes feel short of breath when they're doing things that are pretty basic, like public speaking or standing up too quickly. It's not necessarily when they're exercising, but the shortness of breath does come on and it surprises people. It's not usually a pathologic sign and it tends to be very mild. Overall, however, despite the fact that there's limitations in the lung volumes, there's increased oxygen utilization during pregnancy. And I'll show you a couple of the ways that the lung volumes are diminished, but we actually overall in a result increase, I'm sorry that fast forwarded, an overall increase in some of the lung diameters and a relative decrease in others. So all of this gets to the point that the mother needs to breathe off more CO2 to kind of help sustain the way that the fetus clears CO2, and then also have increased oxygen utilization, despite the fact that many of the critical lung volumes are decreased. So where do we get with nutrition? So nutrition is something we talk a lot about with our pregnant patients. We'll also talk about the weight gain recommendations, but people over the course of a pregnancy need to ingest a lot of extra protein, a lot of extra iron, and a fair amount of extra calcium. And to put this in perspective, there's about 1,000 extra milligrams of iron that are required to support the fetus and the pregnant person as all of the organ systems change and grow and develop. Now, the pre-pregnancy iron stores in a person, though, might be as low as 100 milligrams. So we have to add to that. And if we don't add to that, someone will become relatively or significantly iron deficient during pregnancy. We already talked about the physiologic anemia of pregnancy that can cause fatigue and sometimes limitations in exercise capacity. But if we add iron deficiency on top of that, it can become more significant. So the Institute of Medicine revised the pregnancy weight gain guidelines in 2009. And what they did was they stratified it by pre-pregnancy BMI. So people who are relatively underweight, the Institute of Medicine recommends gaining more weight during pregnancy, so over 35 pounds, compared to people who are relatively overweight or obese, they recommend a lower amount of weight gain. Now, what you can see in this table that's on the right is kind of what all that weight is going to. So it's not just weight gain for the purposes of just growing the fetus so that the fetus can grow and develop. Some of that additional weight and the calories and nutrition that's going into the system is going to the placenta. The weight is in the amniotic fluid, uterine tissue, increase in breast mass and breast blood flow, extra blood volume, etc. So there's a lot of different places that this overall increase in weight goes for a baby that's only going to be about 7 to 8 pounds in the end. So with the changes that happen in all of the organ systems in pregnancy, one of the things that we talk about a lot with patients is the normal musculoskeletal changes that occur in pregnancy. They can be more pronounced in some people and almost insignificant for others. So one of the things people will often ask about is the rectus muscles. So rectus muscles are the six-pack that lines the anterior abdominal wall. And what happens is there is a gradual separation of these muscles during the course of pregnancy, such that they are assisting with like simple things like standing up straight, relatively less at the end of pregnancy than they are at the beginning. This changes the way the posture works, and there's a relative, what we call lordosis of the lumbar spine, which is where people are leaning backwards. That's in this, the figures here. And what that does, though, is it places a lot of strain on the paraspinous muscles. So the paraspinous muscles are doing relatively more work because they're, as I tell patients, this is not really physiologic. The rectus muscles are kind of out to lunch. Like they just take a break. They're on sabbatical for the pregnancy. And then postpartum, as there's no more force for inside the abdominal compartment, those rectus muscles will kind of not snap back into place. They're not rubber bands, but they will eventually come back together, reinforce the anterior abdominal wall, make the core strength better, and put relatively less pressure on the back muscles. In addition, we see changes in the sacroiliac joints with increased mobility in the pubic symphysis, which I'll talk about briefly. There's an anterior tilt to the pelvis so that people can kind of stay upright, given their center of gravity has changed. And this kind of changes the way people walk. And people will often describe at the very end of pregnancy having kind of a like a duck walk or a wide spaced gait. And that's because they need to physically stand upright with the changes in the pelvic tilt. There's increased force across the joints with weight gain during pregnancy and increased fluid retention as well. So with that, I'm going to briefly address several common reasons why people might have to decrease their activity during pregnancy. And this is before we get to the kind of exercise part of the talk. And specifically, I'm going to talk very briefly about a few obstetrical complications for which we actually might recommend the opposite of what this talk is about, which is decreasing one's activity level as opposed to maintaining or increasing it. So very, very commonly, people will have back symptoms during pregnancy. This is more common in people with pre-existing back injuries, people who are older or people who've had pregnancies and especially deliveries before. Some of these cases of back pain will be severe, but importantly, the pregnancy itself does not increase the risk of having disc disease as the cause of back pain. The back discomfort can interfere with sleep and activities. And unfortunately, there's also some large joint discomfort that comes along with pregnancy, including sciatic, hip, and knee pain. So when we talk to people about how they're going to manage their activities in the context of having back discomfort, the American College of Obstetrics and Gynecology has some fairly not useful suggestions. They recommend kind of good shoes, avoiding heavy lifting, or specifically using good lifting ergonomics. They talk about mattress support, lumbar support in chairs, using pillows between the knees, especially for sleep. Heat, cold, and massage. And then ultimately, physical therapy and exercise training is really useful for back pain during pregnancy because the pregnancy continues, the uterus grows more gravid, and these positional changes that we talk about become more severe. So doing something to help support people who are experiencing this early is important. In addition, there's some literature about support belts and acupuncture that they may be helpful in addition for people who are experiencing this. Pubic symphysitis, and Dr. Albright will mention this briefly later when they talk about joint laxity. There is a hormone in pregnancy called relaxin that causes relaxation of ligaments. This can occur in any ligament in one's body, but specifically the pubic bone separates a little bit at the end of pregnancy to accommodate the head coming into the pelvis and then ideally birth. Now, if this separation is more pronounced, it can actually cause very significant pubic discomfort that significantly can limit someone's ability to even walk safely. People have a lot of pain. It's typically down the inner thigh, but can almost experience something like a foot drop. So when people have this symptom, we talk about support belts, physical therapy, graded exercise, and then really optimizing ambulation. Leg cramps are very common in pregnancy, and these are typically something that our patients will describe as, I have Charlie horses at night. They tend to be long lasting. They tend to be relatively severe, and oftentimes people cannot really prevent or predict that they're going to happen. We think this has to do with some buildup of lactic or pyruvic acid during an involuntary contraction of these muscles. There's essentially no proven treatment or preventative therapy, although magnesium supplement may be of some questionable benefit, but strength training may be effective because when the cramp occurs, it can last for many minutes and may be not really responsive to basic things like stretching the calf, walking, ambulation, and may require just a lot of patience and waiting. So those are normal things that can happen in pregnancy: back discomfort, joint laxity, etc. Now, this talk is mostly about people who are going to be doing exercise, are often healthy when they enter pregnancy, and they want to be as healthy as possible during pregnancy. There are some conditions where we actually worry a little bit about exercise training. And so I just wanted to mention those and call those out very briefly. So certain cardiovascular or respiratory conditions may be a little bit riskier to do things, especially like extensive cardio, kind of cardio exertion. And then there are a number of obstetrical complications. So these are things in healthy people who become pregnant and now are having an issue with the placenta that may result in bleeding in pregnancy, and that could be either due to an abruption or a placenta previa. Having high blood pressure or preeclampsia during pregnancy may limit one's ability to exercise. I will talk briefly about preterm labor and cervical insufficiency, as well as multiple gestations, because that's also a professional interest of mine. So just very briefly, preterm birth is defined as anything before 37 weeks of pregnancy and is relatively common in the United States. It's common for a lot of reasons. Number one, some people have the need to have a preterm delivery because they're having a pregnancy complication like high blood pressure, or some people will have a spontaneous preterm birth, and that's because they go into labor or break their water early traditionally. Now, the uterus can go into labor early or can go into labor at term. The uterus is just a muscle. It's smooth muscle that responds to oxytocin as the trigger. And so one of the things that's really important about exercise in pregnancy is that people will often experience contractions with activity, including exercise. Now, these contractions are often considered to be something called Braxton Hicks contractions. It's not really false labor because it's just these passive and mild contractions of the uterus. What this graph shows is that there are actually oxytocin receptors on the uterine muscle after 20 weeks gestation. And so intermittently, the uterus may experience these mild contractions, and not until you get close to term, where there's a lot more receptors and a lot more oxytocin, do people really go into labor. So the first thing that's important about this is that mild Braxton Hicks contractions do not change the cervix, and it's not preterm labor. The second thing that is important is that while they increase with activity levels, they're also not thought to be harmful. Spontaneous preterm birth, this is a very complicated slide, and all you need to know about this is that people can contract and deliver preterm for all kinds of reasons, and nothing on this slide says exercise. So there is nothing that we think that extra activity level in and of itself would result in contractions that could result in cervical change and ultimately lead to a preterm delivery. Now, if there were other things involved, like someone was excessively dehydrated, or say working in a very, an unhospitable environment where they weren't able to eat and drink, they didn't have appropriate rest, that would be a different type of exertion that could result in physiologic stress and then potentially lead us into this preterm birth cascade. Cervical insufficiency is a very rare condition, fortunately, and that's when the cervix changes during the pregnancy or does not work well during the pregnancy. This is a condition in which we often will recommend not doing exercise or not doing hard exertion. Because of the risk of someone delivering early, we often are doing interventions during the pregnancy, and we recommend modifying one's activity level during the course of pregnancy. If someone has twins or triplets, this is a multiple gestation, and that often results in many pregnancy complications and potentially many symptoms. For an uncomplicated multiple gestation pregnancy, people can continue to do a moderate amount of exercise. This may be very limited towards the end. So that's something to consult your physician and really think about how to tailor the exercise to how well you feel at time. By the end of the third trimester, people with multiple gestations often are not really able to do exercises with a significant amount of exertion. They're also winding back on work. They have poor sleep quality, very uncomfortable in general. And so exercise may not be ideal. So just in summary, Braxton Hicks contractions are common. They do not result in typically in preterm birth. They do not require activity modification, but if someone is uncomfortable while they're exercising and having lots of these mild contractions, that is just something to be aware of. Preterm contractions that are serious may result in activity modification, and they may improve. So it's not uncommon for people with real preterm labor or cervical insufficiency to have decreased exercise recommendations during pregnancy. In general, though, this is a key point. We no longer really support the idea that putting people on bed rest during pregnancy actually prolongs their pregnancy. So even for people with risk factors for preterm birth, we very rarely put them on bed rest. But if there is a pregnancy complication that has arisen, it is important to talk to one's physician about exercise, work, and travel, because those things we may have recommendations just to modify one's activities if someone is at risk for delivering preterm. Okay, with that, I'm going to pass it to Dr. Albright.
All right, great. I realize that just like you're the preterm birth person, I'm the hypertension person. I could talk about hypertension and exercise for a long time, but I'm not going to do that right now. So we're going to move on to really talking about exercise and birth outcomes. There have been actually a pretty significant number of studies, some large, some small, some randomized, some not, that have looked at exercise in pregnancy. I'm not by any means going to go through all of them, but just going to try to give a general overview. So the American College of Obstetrics and Gynecology, or ACOG, is kind of our governing body that really tries to give us guidelines that are evidence-based to kind of support how we practice medicine for patients who are pregnant. And this is what they say about exercise. So physical activity and exercise in pregnancy are associated with minimal risks and have been shown to benefit most women, although some modification to exercise routines may be necessary because of normal anatomic and physiologic changes in fetal requirements. And so Alyssa, I think, just really very nicely went over some of those physiologic and anatomic changes that might just really make someone need to kind of modify their exercise, and some of the fetal requirements with which we as physicians would recommend changes. Go to the next slide. Alyssa, I think you're still controlling the slides. Thanks. Perfect. So this is the kind of big slide that says that multiple studies have shown the benefits of exercise in pregnancy. And so, like I said, there have been randomized controlled trials where they have randomized patients with different, in both a normal pregnancy and in more high-risk pregnancies to standardized exercise regimens. They've looked at patients who are normal weight, overweight, and obese, and have looked at different exercise regimens. They've done observational studies. So this is kind of a conglomeration of lots and lots of trials. And really compared to those who are sedentary, aerobic exercise, and most of these have focused on aerobic exercise rather than strength training and weight training, of anywhere between 30 and 90 minutes. And this is, again, based on the number of studies that have been done. Anytime between 2 and 7 times per week. Again, different studies have looked at different things, really lower the risk of all of these things. So they lower the risk of excessive gestational weight gain. And Alyssa commented on what the Institute of Medicine guidelines are for appropriate weight gain in pregnancy. We know that excessive weight gain leads to additional pregnancy complications, and not surprisingly, exercise reduces the risk of excessive weight gain. Also reduces the risk of gestational hypertensive disorders. And so those are things like anything that's related to high blood pressure in pregnancy, as well as preeclampsia. Reduces the risk of gestational diabetes, or diabetes that arises during pregnancy without a history of pre-existing diabetes. In some studies, it's actually been shown to reduce the risk of preterm birth. I know that a lot of times there are concerns with some of the situations that Dr. Stephenson-Famy talked about, that we don't want people to heavily exercise in order to not have them deliver preterm. But in healthy pregnancies, many studies have actually shown a reduction in risk of preterm birth. Operative vaginal delivery is when we kind of help to assist in delivering a baby vaginally, either by something called forceps or a vacuum. It's been shown to decrease the risk of cesarean delivery. And then there have been some really interesting studies that have looked at kind of postpartum recovery. And regular physical activity actually has also been shown to decrease the risk of postpartum depression and also improve your postpartum recovery. So you do have a lower risk of a prolonged recovery. All right. So what about patients with medical problems? So most of the data, or really in most of the studies, especially if we're taking people and saying, you exercise, you don't exercise, most of the studies have looked at people without underlying medical problems. But there was one particular randomized controlled trial that I liked, that I thought was very interesting, that was published pretty recently, that looked at patients with pre-gestational medical conditions, so medical conditions that they had prior to pregnancy. And this, and in particular, they were looking at chronic hypertension as well as both type 1 and type 2 diabetes. And they put them on an exercise, they put half of them on an exercise regimen and half of them on their kind of standard routine, didn't actually prescribe an exercise regimen. And noted that those who undertook this exercise regimen had a reduction in the risk of cesarean birth by about half, which is in obstetrics and in most medical things is like as big of a risk reduction that we really ever see with anything. Of course, these are people that are enrolling in a trial who are interested in exercise. It's hard to know exactly if this is the true risk reduction, but it's really hard to see these numbers in really any other trials that we do, and didn't increase the risk of adverse maternal or neonatal outcomes. All right, next. And I'm going to make you click through this because there's some animation. So one of the big questions that we get asked, or that I get asked, especially as a high-risk doc, is that, well, if I exercise too much, am I going to make my baby too small? And the answer, as you can see here, is no, you're not going to make your baby too small. Okay, you can go on to the next. So there have been 3 big meta-analyses, so just big conglomerations of a bunch of different studies that looked at all of that prior data that I looked at that said, but that I commented on about exercise regimen versus those who either are not prescribed an exercise regimen or are sedentary. And the differences in birth weight is really minimal to none in patients who exercise during pregnancy compared to controls. There's a little bit of a differentiation when we're talking about like true elite endurance level athletes. If you have someone who is a professional athlete, which I am not, most of us are not, but who's really, kind of going back to that kind of Paula Radcliffe at the very beginning, winner of the New York City Marathon, and are exercising really intensely, vigorously throughout the entirety of pregnancy. Some of those studies, when looked at, showed that infants do weigh a little bit less, 200 to 400 grams, which is not actually all that much, but without actually an increased risk of the baby being, quote unquote, too small from like an obstetric or a neonatal perspective. So yes, vigorous activity may reduce birth weight a little bit, but without actually being pathologic. All right. So these were some other studies that I saw that I just think is kind of interesting. These are small studies. I don't like, this is not stuff to take home and like hang your hat on and say this is definitely true. But all of them seem to kind of go in the same direction. And when I'm looking at studies, when we're looking at studies on really anything, if everything is seeming to be pointing in the same direction, then I tend to believe even the smaller studies. And so duration of labor has been shown to be kind of inversely associated with aerobic capacity. So if you are more in shape, you might be in labor for less time. So great. So even if you're not in shape at the beginning of pregnancy, maybe it's like behooves you to increase your aerobic capacity during pregnancy because it may help in the labor process. Similarly, exercise beyond the first trimester seems to shorten the first stage of labor. So that's the stage of labor from when you start labor until when you're completely dilated. So when there's no pushing, your body's doing the whole thing, but it seems to be potentially shorter by up to 2 hours, which is significant when one is in labor. And also seemed, and then kind of overall thinking of kind of overall shortening labor by maybe about 8 hours. There have actually been some other more interesting studies recently that I was able to find that showed that the babies also may benefit from exercise. These are hard to really tease out, in part because patients and people who choose to exercise may also be choosing to do different things postpartum, both with their children. They may lead different lifestyles than those who are not exercising. But in a couple of studies that have looked at this and have kind of really evaluated infants after birth, the babies in whom their moms or their parents exercised had slower heart rates and greater beat-to-beat heart rate variability, which is just kind of a marker of better cardiac conditioning. And actually, one really interesting study brought the babies back at 1 month and just looked at motor development and saw that babies in whom had been exposed to exercise antenatally actually had a little bit of accelerated motor development. None of the other babies were delayed by motor development, but there was some thought, and it was an interesting paper to read, that the significant movement around by someone exercising during pregnancy may have actually helped in the motor development of their babies. I don't think these are studies to don't hang your hat on them. I don't think this is the reason to exercise or not exercise during pregnancy, but I thought it was interesting. All right. There is a whole lot more out there about all of that, but overall, I think that it's just important, the kind of takeaways for birth outcomes are that, generally speaking, for the vast majority of low-risk patients, we see better birth outcomes with patients who exercise in all forms. All right. So moving on to just a couple of rules of thumb for exercise, things to think about, and I'll editorialize a little bit here, and Alyssa, please feel free to also editorialize a little bit here as you see fit. So the actual recommendations are at least 150 minutes of moderate intensity aerobic activity per week during pregnancy and the postpartum period. That 150 minutes isn't recommended to be all at the same time. It's ideally spread out over the course of the week. And it's generally, and I put generally in quote, in italics, okay to continue the same routine as prior to pregnancy. And I'll kind of dig into that a little bit more as we keep going. Okay. Next. So what is safe during pregnancy? So this was just an interesting review article published in 2017 that I thought was kind of interesting to point out. and I think summarized most recommendations nicely. So when should we start exercising? Well, whenever, first trimester, continue from beforehand, or really at any point during the pregnancy that you feel comfortable doing so. The duration of exercise should maybe be between 30 to 60 minutes, 3 to 4 times per week. And then I'm going to jump to the end here. So, if it can be supervised, great, but, probably okay. Most people aren't having someone watch them exercise. And when to end? Well, when you deliver, or actually, this is during pregnancy. Continue exercising after delivery, but I have a couple of comments from just the postpartum perspective as well. I do want to kind of point out, because this is something that comes up when I talk to patients about exercise really, really, really commonly, as there's this kind of, how fast can my heart rate get? And is it bad if my heart rate gets too high? And so what this article proposes is that the intensity of exercise should be somewhere between, less than 60 to 80% of the age predicted maximum maternal heart rate. And then you see that there's the little, the asterisk, and you read at the bottom, it says usually not exceeding 140 beats per minute. I have literally no idea where this recommendation came from, and I'm going to comment on why in the next slide, and then just, like I said, editorialize a little bit. So we know that your maximum heart rate decreases with age. And this is just I just literally did a Google search and said, maximum heart rate with age. There are lots of different calculations. Your maximum heart rate is going to be different than someone else your same age based on lots and lots of things. But generally speaking, if we say a maximum heart rate of a 20-year-old is 100 or is 200, and 50% of that, or 75% is 150. But if we kind of think about that 60% threshold, not most of our patients aren't, many of our patients are between their 20s, 30s, early 30s, and 140 beats per minute is maybe 60% of that. So it's it doesn't really make there's no physiologic. There's 140. There's no physiologic cutoff that says if faster than 140 beats per minute is a problem or inappropriate. And so my take away from this is that generally speaking, the thought is that we want people to be engaging in aerobic exercise. And if you are kind of into exercise physiology, you may have kind of heard there's aerobic thresholds when your body is using aerobic metabolism to exercise. And then at some point you transition into anaerobic, your body you are exercising so hard that you are not you are needed to use other sources of energy rather than just the oxygen that you are taking in. And that is when you switch over to anaerobic metabolism. This can be tested in an exercise lab if you're really interested to know exactly where your thresholds are. Most people don't know where their thresholds are. But there, I think, there's this myth out there that if we have patients who are pregnant anaerobically exercise, they will increase their lactic acid buildup, which may impact the fetus. We know that acidosis in general, in the setting of diabetes, is really bad in pregnancy. But we really have no idea whether nutritional acidosis, so ketosis for kind of dietary things, or whether lactic acidosis in pregnancy is problematic at all. And because if you come into pregnancy very aerobically fit, or if you are someone whose heart rate just runs a little higher, and when you start running, your heart rate's 145 beats per minute, that doesn't mean that you can't run. That's just your physiology and who you are. So go to the next slide. So and then click through one time. So what people have actually started to talk about a little bit more, and I think for me makes a little bit more sense, is to really think about talking about kind of exercise based on a self-reported intensity scale rather than using a heart rate. And for most people, it actually aligns with your heart rate pretty well if you've ever done heart rate training, but it's not perfect, and everyone's going to be a little bit different, is I think one of the important things here. And when we've looked at when people have done exercise physiology and pregnancy studies, people have different heart rate responses than they do when they're not pregnant. And so using just a pure heart rate cutoff seems really not appropriate for most people. So go to the next slide. So this is this is a perceived exertion scale that is used in some exercise physiology literature. And which goes from like, they have 6 to 20, but 0 is like sitting on the couch. And 20 is like the hardest you can possibly exercise for the shortest period of time. And so moderate exertion, we kind of put in this like 13 to 14, that it should feel somewhat hard, which again, is going to vary by person, but that's probably okay. Like what is somewhat hard for me is going to be different than what's somewhat hard for you. And that's fine. Another, I think, really good way to kind of figure out whether people are like aerobic or really over exercising is to use the talk test. So if you can kind of talk, maybe not like carry on a very prolonged conversation, but if you can speak while you're exercising, that is a good indication that you are in an aerobic range. Again, I'll say we don't actually know that being anaerobic is a problem, but because of these theoretical risks and because we are very conservative oftentimes when it comes to our pregnancy recommendations, we say, well, maybe stay in, generally speaking, in the aerobic range, or don't have like really prolonged anaerobic exercise, especially if you're someone who has never really done that in the past. Like don't start doing CrossFit if you were not doing CrossFit. Okay. So what are types of safe exercise? This is just a list of examples, which I think is that leaves a lot to the imagination. But I think that maybe more important to think about rather than like what can you do is what you shouldn't do. And so contact activities with a high risk of abdominal trauma or high risk of being imbalanced should potentially be avoided. And I put this is likely trimester dependent. So, I mean, if you are really into martial arts, maybe being kicked in the abdomen is not great. Maybe don't do that. If you, and we often will say horseback riding, if there's a high risk of falling, being kicked in the abdomen, probably try to avoid. But then there are going to be some people who are very skilled horseback riders who, like, again, you take this, really kind of think critically about it. Skiing often comes up in the Pacific Northwest. Can I ski during pregnancy? Well, it kind of, I mean, it depends. Like, are you in the first trimester, how competent are you skiing? Are you going to be so careful that you're actually more likely to injure yourself? Well, then, how worried are you going to be about it? Versus if you're at 36 weeks pregnant, like, then maybe your balance is going to be off. Maybe you don't want to do that. The other thing is that scuba diving should be avoided because of the inability of the fetal pulmonary circulation to filter bubble formation, which is, I don't know how many people go scuba diving for exercise, but put that out there. I see something in the chat. I'm not really monitoring the chat about bicycle riding. So cycling is one of those, is I think maybe something else that's really important to think about in Seattle, because Seattle is a pretty big like cycling community. I put that into, for me, the kind of trimester dependent category of exercise, in that first trimester, second trimester, like go ahead, like no problem. Third trimester, honestly, I mean, to be fair, I biked to and from work probably up until maybe 32 weeks of pregnancy. But I am actually more worried about someone hitting me and me falling than me falling on a bicycle. And that trauma is really what we're trying to avoid. It's not so much the like the physical act of cycling. It's the kind of risk of injury during the activity. Similarly, I've talked to people about rowing. Rowing, totally fine, but at some point in the third trimester, you might not be able to do that motion just based on kind of where the uterus is in relation to how you actually want to do a rowing machine. Alyssa, you unmuted.
Oh, I would just say, I always recommend for patients to think about the conditions in which they're doing these situations. So the gestational age is really important, but like cycling in Seattle is not all that safe. I mean, it's safe in some areas. Now, if I have someone who lives in a location where they have no cars on the roads, they're not doing mountain biking necessarily, they have a very low fall risk, then there's no reason, that's like about as safe as walking. So in a lot of contexts, I think that cycling is okay. I think that the experience of having people come to us, we live and work on a labor and delivery. I would say I live on a labor and delivery unit, which I practically do. Work on a labor and delivery unit where people come in after abdominal trauma from falling or being hit by a car is really terrible. And so that informs some of our recommendations, but it's not evidence-based. So it's like in Seattle, where bicycle accidents are common, you have to be incredibly careful. But in lots of other places in the world where people may cycle, it's like about as safe as walking. So there's no reason that one couldn't do that. The other thing that I have definitely talked to people about is that sometimes upright cycling, especially if they're doing indoor cycling, becomes less comfortable because there's a lot of pressure on your perineum, the vulva. It's just like there's a lot of pressure on the cervix as the uterus turns into the size of a watermelon compared to the size of a pear. And so actually recumbent cycling is kind of amazing. So for people who are having really want to get their heart rate up, they want to do more than walking, they're indoors and they have access to a recumbent cycling unit, that is a way actually to take the pressure off the pelvic floor entirely and really just use your hip flexors to bike. So we think that thinking about one's conditions, like external in the universe, not cycling in icy conditions, for instance, other things that you would potentially lead to a fall around other cars, I mean, even the Burkeman Trail here in Seattle is questionably safe, depending on how busy it is. So using good judgment, I think, is more important than actual, like, the absolute risk, because we really don't have data to support any of this. And I guarantee there are parts of the world where people cycle the entire time and get on a bike immediately postpartum, and it's fine. In Europe or Amsterdam, where there's amazing bike trails, and that's the culture.
Yeah, I completely agree. All right. I have a couple more slides and then we're happy to answer questions. Just click through this. So can I lift weights? I think the general answer is yes. But I put it within reason. This was actually looking at kind of occupational weight, like lifting weights. So a study looking at kind of occupational exposures. So really heavy lifting for a long time, day in, day out, may be bad, but like probably lifting weights in pregnancy is fine. Keep going. If you're thinking about endurance trainings, prolonged exercise, the general recommendations are to avoid prolonged exposure to heat because we ideally don't want you to raise your body temperature all that much. And then of course, paying attention to hydration and caloric intake, as Alyssa commented on. And then my food for thought is that the other thing that I will talk to people about a lot is that, as Dr. Stephenson-Famy commented, musculoskeletal changes and the increase in joint laxity may increase the risk of injury, especially if you're doing things with kind of rapid side-to-side kind of motions. And if you click again, I promise you no orthopedic surgeon will touch you if you tear your ACL during your pregnancy. And so then you will be miserable throughout the entirety of your pregnancy with a torn ACL. And that's like not necessarily dangerous, but really uncomfortable and really like kind of thinking critically about like what you're doing and what the risk of injury is. There are lots of reasons to stop exercising during pregnancy. I keep this here. I'm not going to go through them, but these are kind of talk to your physician if you're kind of experiencing any concerning symptoms that are related to here or potentially otherwise. And then I do want to comment quickly on the postpartum period. So most people will reduce their exercise postpartum just because for lots of reasons, whether it be a prolonged or complicated postpartum course, the kind of having to newly take care of a child takes a lot of time and can be really difficult to kind of engage in an exercise routine. There have been studies that have looked at the fact that regular aerobic exercise really does continue to improve cardiovascular fitness. And if you're lactating or worried about that, doesn't affect milk production, composition, or infant growth. From like a discomfort standpoint, most people will actually recommend pumping or feeding before you exercise, especially if you're doing something like jogging. But there shouldn't be any kind of concern from a milk production standpoint. And then how soon can you start exercising? Well, kind of as soon as it feels comfortable to do so, with a couple of modifications. So, walking immediately, pelvic floor exercises pretty immediately, as long as you don't have some major laceration that occurred. And then honestly, abdominal strengthening exercises have been shown to really bring those like those rectus muscles that Alyssa talked about back together. And so starting those carefully, almost immediately postpartum has been shown to be safe. One of, I think, the silver linings of COVID has been a huge mass of online videos that are, pregnancy yoga, postpartum exercises that, some are really good and some are not that great, to be fair. But, a lot of these things are things you can do at home. The other thing that I tell people postpartum, especially if you really kind of stopped exercising a little bit in the third trimester, is that you also don't want to jump right back into whatever exercise routine that it was beforehand. Listen to your body, really pay attention, start slow. A lot of things that seemed really easy to do 6 months before are no longer going to be easy, because those muscles just have either been stretched or have been underused, and are now kind of underdeveloped and just need to be re-strengthened. I'll leave this in here. I know that we'll share the slides. I have the Canadians, I think, are sometimes way ahead of us. I found some really cool like exercise prescriptions throughout some of like the Canadian departments of health. This is one of them about like, when do you start? What are your target heart rates, et cetera, which all seem kind of very reasonable. The next slide includes, again, kind of another, like, this is from the University of Alberta, like, what should I do? What are some of the safety considerations? I think that these are kind of really nice, just resources. So in summary, I think that we've hopefully convinced you that some symptoms of pregnancy might limit training. If you have a high-risk pregnancy, if you're having any concerns, please contact your physician and kind of talk through what is safe, what is not safe. But generally, you can you can start or continue exercising throughout the entirety of your pregnancy. And my little like soapbox is don't worry so much about your heart rate, but think about your perceived effort. And then my final plug is that one of my cardiology colleagues and I are doing cardiopulmonary exercise tests on pregnant people. If you're interested in knowing how your exercise physiology changes in the first versus the third trimester. Our goal is ultimately to use this information to look at some patients with cardiovascular disease, but we don't have any kind of recent up-to-date data on cardiopulmonary exercise, like bicycle exercise testing in pregnancy. So if you happen to be pregnant or know someone who's pregnant who's interested, let's. And with that, we have, I think, 7 minutes for questions, and we'll go from there.
Okay, I might stop my share so we can see all the questions in the chat. And I think Hannah put the Q&A in the chat for us, so that would be great.
Oh, okay, great.
There's a question about hiking at altitude. So in the Northwest, we have amazing mountains, and they're not, with the exception of Mount Rainier and going to the top of Mount Baker, they're not that tall. So in general, I would say at moderate altitudes, kind of 3,000 to 8,000 feet, probably for short durations, there's, maybe minimal symptoms of shortness of breath in addition to your own pregnancy kind of dyspnea, if that happens. I would say for short trips, so for people who are not acclimated to being at altitude, I would say it's probably not particularly recommended to go above 10,000 feet recreationally, kind of for no good reason. But again, that's
and some of the data actually even looks at like 6,000, like at Denver, like 6,000 feet. People at sea level looking at Denver, and they're like 6,000 feet, totally fine. But there's just not a lot of data that looks at kind of exercise physiology in pregnancy at 10,000 feet. Like we just don't know. Probably if you live at 8,000 feet, going to 10,000 is probably okay. If you live at sea level, like kind of the compensatory things that your body needs to do are going to be very different. If like me living in Seattle goes to climb Rainier compared to like me when I lived in Denver going up to 14,000 feet, it's just a different thing. So, but generally speaking, 2,000, 3,000, even up to 6,000 feet is generally considered totally safe.
Yes, and the same recommendations for kind of safe exercising with another person. I had one of my own personal pregnant patients fall hiking downhill recently by herself at 32 weeks and came in really scraped up, and there was no complication, but that was, it's good to use hiking poles on the way down. Your balance may be impaired in the third trimester. And so really using safe technique to avoid falling, I think is kind of one of the things to consider.
Let's see, there's Starting to exercise versus continuing to exercise. There's both. So it's actually there's literature on both. And the if you're starting, you generally have to start slower. If you're continuing, you can generally continue what you're doing with kind of the reasonable limitations. But the most of this is either starting or continuing. Of course, they're going to have to be different modifications based on if you've never exercised before and are starting a new regimen, you're going to have to start at a very different level. Which is again why I think that like perceived exertion bar is I think really helpful, because it might just be that walking is plenty of exercise at the very beginning, and then you can kind of continue to increase from there.
There's an interesting question about pelvic floor physical therapy. And so there are lots of considerations about when to start pelvic floor physical therapist with an actual physical therapist. So oftentimes if for someone's had a vaginal birth, we need to wait until all lacerations are healed. And so waiting until 6 weeks is probably reasonable. Also, there's a little bit of, the nerves that supply those muscles are probably a little stunned right after vaginal birth. So it may not be that effective until you get a little further recovered. But doing things like home Kegel exercises is not harmful. It may not be super helpful until you get a little further out, but there's not necessarily any harm to doing home exercises. So I think that if you're doing kind of intravaginal therapy with PT, they probably do want to wait until 6 weeks, which I think is quite reasonable.
Yeah, no, and sorry. Thank you for pointing that out. Those are good clarifying questions. There's pelvic floor PT before delivery.
Yeah, it's a great idea for everyone. I mean, there is actually not enough pelvic floor therapists in the city of Seattle to accommodate the number of patients who are interested in this. And I think it's great. I think that seeing a physical therapist, getting a sense of how to do some of the exercises to kind of prepare for birth is truly amazing. So if you have patients that are interested in that, or even if they can only have one visit and then get some home exercise regimens, and then you have an established relationship. So if they do have a difficult time with a vaginal birth, then that relationship is already there, so they can go back to them postpartum. Because we often see people only referred for postpartum, and then it can take a while to get a new appointment.
The problem is there just aren't enough pelvic floor physical therapists, and so it can be, we have a good affiliation with some of our pelvic floor physical therapists, and they're good about getting people in postpartum, but really do try to get people postpartum. So I've had a harder time getting people in antepartum unless there is like a concern, but it's absolutely worth a try.
There was a question very early on about nutritional recommendations. So there are a wide variety of nutritional recommendations, like per day of kind of protein intake, iron intake, calcium intake. The issue is that one during pregnancy needs to eat to sustain themselves and their own muscle mass, and then provide some extra for the developing uterus, the placenta, and the fetus. And so over the course of one's pregnancy, one needs hundreds of extra grams of protein, but in an individual day, you probably need just a few. There's a lot of really interesting studies looking at people with severe nausea and vomiting of pregnancy and hyperemesis, where people are like unable to sustain their macro or micronutrient goals during the course of pregnancy. And ultimately, the fetus does okay. And it's because the placenta is very adept at kind of finding nutrients all over one's physical body and stealing them. So that's kind of why if people are not taking enough protein in, that the protein will still be sent over into the fetal compartment, but at the expense of maternal muscle mass. So it is important, if possible, during the parts of pregnancy where people are able to eat, which is usually like the second trimester, this is the best, that they're getting the macronutrients. And then I usually tell people like, not to get too worried. Like if they're not hitting their exact macro or micronutrient goals or their weight gain goals, as long as the fetus is growing and developing normally, not to worry that that's going to cause a devastating pregnancy outcome, because it likely will not. Based on kind of like long-term epidemiologic studies of people who were delivering in like wars and famines. Turns out the fetus does okay. It might be a little smaller on average, but in general, there's not a higher incidence of things like growth restriction that Dr. Albright talked about. And I think that might be it.